3, so then again, you're gonna pick 3 out of a bowl. Because we don't just sit here and go, oh, you can do those 2. You know, it's obviously very random because you will be choosing it. So, checking off for neuro, you're gonna assess mental status and level of consciousness. How are you gonna do that?
By talking to them.
Mm-hmm. How do you assess level of consciousness?
Ask them, it's person, place, and time, so like date and who they are.
Yep. So you come in and say, you know, I'm going to be doing your exam today. If you feel awkward just like walking in and not saying anything at all, you can go ahead and do that. So then you're going to say, I'm now going to assess mental status and their level of consciousness. I know they're alert and awake because they're up and looking at me. Can you tell me where you are, who you are, what day it is, who's the president, whatever questions you want to use for that, that's totally fine. And then you're going to say, I'm also going to evaluate speech. I'm going to do this based on conversation as and with cranial nerves, because you're going to have them repeat something, you know, for your like the light tight dynamite thing. So you're going to go through and assess your cranial nerves 1 through 12 that we've been practicing. So that just roll right through them. Remember, we're only going to just talk about cranial nerves 1 and 2 because it's going to take forever, you know, to have them run through a Snellen's or whatever. So just explain, like, I would test the optic nerve by using the Snellen's chart, having them stand 20 feet away, close one eye, read all the way down, switch, have them assess their near vision by either using a newspaper or a brochure that's in the office, or you can use the Jaeger or Rosenbaum. And then you move on to cranial nerve 2, that's my olfactory nerve. I would have them close their eyes and see if they can identify a common smell, so coffee, etc. Go through the rest of those, and then evaluating extremities for the deep tendon reflexes. Like I said, if you cannot elicit a response, it's fine, don't panic, just say my expected response is this. Like, don't just hit it once, not get it, and say expected response. Try a couple times, be like, okay, expected response would be flexion of the arm, extension, etc. Make sense? Any questions on neural? Pretty straightforward. So then for your cardiovascular, this is where things get tricky, is because you need to remember when it says inspect, that you're just inspecting. Inspecting is not touching, it's not feeling, it's not listening, it's just looking. Okay, so again, this is where you're really going to have to talk through it. So you're going to say, I'm inspecting their general appearance, color, breathing efforts. You know, color is appropriate for race. They don't appear to be cyanotic. She's sitting comfortably. Doesn't appear to be any distress. You're going to inspect the jugular vein. So that's when you have them lay down and bring the head of the bed up. Remember that?
Mm-hmm. Until you can see it, or until it disappears?
It happens differently with everybody. Okay. So very thin athletic people, you might be able to see it laying down, but by the time you raise the head of their bed and gravity takes the extra fluid out, it'll collapse at like 35, 40-ish degrees. So just say you're inspecting the jugular vein. You can also have them lay down and then use the pen light and shine it on their neck to see if there's any jugular vein distension. That's another way of inspecting it. So then you're going to inspect the anterior chest for lesions, heaves, lifts, and pulsation. So you're inspecting, everything looks fine. Inspect and palpate for any extremity edema. So this is where you're like, I'm inspecting for edema, I am now palpating for edema. Okay? Makes sense? So palpate and compare the pulse sites. So we'll run through these. So where's your temporal? Okay, and then your carotid, brachial, like brachial, yep, on the inside of your muscle, right?
Mm-hmm.
Where you feel for the blood pressure cuff placement, okay, and then radial, yep, and then your femoral, we're probably not going to be doing that one, because that's violating our personal spaces. Your popliteal,
behind the knee,
dorsalis pedis,
on
top.
Yep, so
First and second toe.
Yep, kind of like right up from the big toe on like the arch of your foot. Yep. And then your posterior tibial.
Above that.
Yes. Yep, so you'll just have to do 2 of those, and since you have like 2, you're going to assess both, right? Because you have 2 temporals, 2 carotids. Make sure you do both sides, okay? Then you're going to auscultate the carotid arteries. So remember those 3 spots I showed you? And of course there's not going to be a stethoscope in here. Anyway, so up by the jaw, the middle, down by the collarbone. Okay, and what part of the stethoscope are you going to use?
Bell.
The bell. Very good. And then you're going to auscultate the heart areas, and name them while you're going through. So you're going to say, what is this one?
Aortic.
And then?
Pulmonary.
And then?
Herbs.
And?
Tricuspid. Mitral.
Yep, so make sure you don't just buzz through, actually try to listen, you know, show good technique of how you're going through it and listening to their heart sound. What part of the stethoscope?
The diaphragm.
You can use the diaphragm. Yeah, I'm okay with that. Your book says go through with the diaphragm and then go through with the bell, or throw them on their left side and see if anything changes, but that's usually when things get a little bit more intense if something's wrong.
So
go
for
ahead.
that one, like when we're doing it on our partner, let's go for like athletic type stuff. So do you want us to stick like our diaphragm down like in their shirt and like underneath their shirt, or how do you want us to do that?
I mean, yeah, you could if they're comfortable with that, but if it's someone you don't really know and you're like, "Ugh," I'm okay with you going over the top, but with a patient you would never go over their clothes, right? Never, ever, ever, ever. But for this purpose, we can respect each other. Any questions about cardio? That all makes sense? Okay? And then respiratory, so again, you're going to inspect general appearance, posture, and breathing effort. You kind of did that already with cardio, so you can say, you know, in regard to cardio, I assess this, still looks the same. Inspection of skin, nails, and lips. So you're looking, skin, nails, lips, everything looks fine. For the nails, you can touch them a little bit to make sure that they, their cap refill is fine. Inspection of anterior and posterior thorax. So again, just looking, auscultate, posterior, lateral, and anterior. So how many spots on the front?
8 to 10.
Front.
6 to
6 to 8.
8.
Okay, side.
8 to 10. It's 4 to
And then
6.
back?
8 to 10.
8 to 10. Okay, so again, this is when you're going to be communicating with your patient and say, you go ahead and breathe at what's comfortable for you, and I'm just going to move my stethoscope every time you take a breath. Okay? And then you're going to percuss the posterior thorax. Again, don't panic if you don't think you're getting a good resonant sound. I'm not going to go through and be like, oh, no, that was dull. You hit a rib. That was not in between. Just do your best and show good technique. So that's when I usually go in the spaces that I would auscultate on the back, and I just kind of tap a couple times and move over and down and over, down and over. Does that make sense?
So do you need to feel specifically for like?
Do your best to like feel for in between the ribs, but don't waste all of your time trying to feel in between your ribs to get a good percussing sound. Okay. And then palpate anterior and posterior thorax, detecting tenderness, bulges, and crepitus. So again, you're going to say, I'm palpating for tenderness, bulges, and crepitus. Okay. Because we're going to talk our way through it. Then you're going to palpate posterior chest wall for thoracic expansion. How do we do that? Pinch, hem, deep breath in and out. Yep. And then palpate the wall for tactile fremitus. And how do you do that?
99, yeah.
Mm-hmm. So just remember, talk your way through it, because when you talk your way through it, it usually goes a lot smoother for you.
And tactile fremitus, you want us to go, is it up and down, or is it to the sides again?
You can go to the side, or I use both of my hands and have them say 99,
99.
because then I can assess
99.
Okay.
Because then I can compare both
I like
sides at the same time. But if you want to go side to side, that's fine, just as long as you're comparing both. Any other questions? So again, I would like to check your books today for your course packet materials or whatever. So make sure that those are done, because we can get it out of the way now, so you don't have to worry about bringing it to your competency. We'll be here Thursday from 8 to noon, so if you guys want to come in and practice, I'll